Here is a case of small child, 10 years girl child with ideal indication for ECIRS. These are the three stones which are present in pelvis and two calyces. This is the picture. Anybody thinks that PCNL can remove with a tilt from the lower pole or upper pole? You may think like that. But having an access from below and above, if the system is like this, where the narrow infundibulae, long calyces are there, because the volume is more, I am doing supine PCNL. There is nothing new here in supine PCNL. I attempted inferior calyx, which is anterior. So I have taken time. The puncture after two attempts, the guide wire has gone. This is the third attempt, honestly, where 1 centimeter anteriorly I was there above the iliac crest, but when I went 1 centimeter posterior, perfect alignment with calyx has come. Now guide wire has gone into upper calyx and came down. I thought 99% in supine PCNL, you can go to all the calyces, but you can observe the angle here, it was not possible. So ultimately, because of the access sheath which acts as the ureteric catheter, access sheath with obturator acts as the ureteric catheter, helps in passing the flexible scope any point of time when the PCNL surgeon cannot get the stone. Second point, here I have used laser fiber of 600 micron with 3.5 watts and 10 hertz. This is very powerful thulium fiber laser setting. This setting happens in the bladder mode, bladder stone mode. In no time, honestly, this is an unedited video of entire thing which took around 12 to 15 minutes of time, including the RIRS part. So these fragments you don't require forceps, as in supine PCNL, gravity aided drainage will be there. So I have removed these fragments and I thought I can easily go into the upper calyx and remove all the stones in the upper calyx and middle calyx. But when I went inside like this, these are the stones still left at the pelvis. As I mentioned, it is unedited video. Maybe this part of the video is not interesting because all these stones are coming out with the repetitive movements of the scope in and out. This is the one small stone. Sometimes in problem with the supine PCNL is stone migration to the upper calyx is common. That also I will show here. Two fragments were there and those fragments are removed. Now I am going to the upper calyx. I thought this is the upper calyx, but laterally two fragments, these fragments were there which were migrated into the upper calyceal region. They immediately came down. That is not a problem. But sometimes they also can go into a calyx which cannot be reached. That is also a disadvantage of supine PCNL, but not a big disadvantage because flexible scope person can come. See, now iliac crest is coming in my way to take this stone, so that I have to compress heavily. In prone PCNL you will compress on the buttocks, whereas in supine PCNL you have to compress laterally on the iliac crest. That is a problem, especially if the leg is partially flexed. Now coming to the stone, now flexible scopy person has passed the scope into the calyx, which is present extreme lateral of the calyx, and he tried to do delivery of the stone with the basket, but this stone is bigger for RIRS surgeon. So then what happened, sometimes people ask, can one surgeon do this? Yes, it can be done. I was doing PCNL. Because the basket was not coming, I thought I will try. What I did was, in this case, I have seen from the nephroscope point of view whether I can reach that or not. Obviously, I am not able to reach. So I have not tried anymore because torsion of this thing can occur. So I went to the flexi side. This you can go, but two monitors are compulsory. Again, removing the monitor is not easy. Now what I did is, I went down to see the bottom of the stone. Many times I mentioned that in RIRS, if you can see the bottom of the stone carefully, you will be easily able to get the stone out, either with the basket or see, this is the important point where I am going bottom and lifting the stone. I am going to bottom of the stone, and then with flexible scope without basket, I'll try to lift it up with whatever experience I have. I thought it is freely moving. Freely moving stone is very good for RIR. See, it came out. Now I came to know that it is into the upper calyx. I quickly moved to the nephrostomy tract side, and when I went, I pushed like this, and I immediately moved to the myself. I went to the nephrostomy side, and I could see that, and I could get it. When you see with the nephrostomy, it looks smaller, but it was not coming out. 2 times, 3 times I tried. It is a futile attempt. Take the laser, make into 2 pieces, and take it out. It's a matter of 1 minute time. Not a big issue. In fact, honestly to mention, I am using here the pump to have good vision in supine PCNL. In supine PCNL, I use pump because if you use gravity, some amount of the bloody field will be there. This is again a small disadvantage. See, here I am using laser with nephroscope, ureteroscope in situ. That is not correct. The ureteroscope person said that I will take out into the ureter. So immediately the stone is removed, and the other fragment also came out easily. That means 2 pieces in 1 minute. These things are done. Now one more stone is there. When we have done C-arm, one more stone parallel to my nephrostomy tract is there. These might have been difficult for PCNL surgeon to handle. Now this is upper calyx, lateral medial. Now this is a long calyx. This is a long calyx, and I tried even with the nephroscope whether I can reach, which is unlikely. See, this is my nephroscope. I am not able to go with the flexible scope. This entire thing is recorded with cell phone to make 3-dimensional possible. See how much I am applying torque on the lateral part of the iliac crest, which is not possible. Forget about the infundibulum. The iliac crest won't give. This patient is thin, in fact. So now I went back to the PCNL, the flexi side. This was small stone, I know that, and when I delivered the stone like this, I have pulled out the stone and taken it out simply, and a nephrostomy side surgeon is there and he is ready to catch it. So see, this is the live video where he brought it down, and nephrostomy person is holding it. He is taking it out and taking it. This is nothing new. We have done many cases, but in this case I thought a short period of 10 to 15 minutes ECIRS could clear 100% the stone, and this is the contrast. We are ejecting only for academic purpose at the end, otherwise there is nothing here. And I always do nephrostogram while coming out of the nephrostomy tract. So see here, I am slowly withdrawing the ampullus sheath, that is the flexi guided RGP. Now nephrostomy guided RGP I will do through nephroscope, but before that we have to stent. There is no need to blindly do it, and this I was observing how my puncture is. So this is a stent, came pushed from access sheath below, very easy, especially in female. I held it, he removed the access sheath, he has seen the stent in the urethra, so 100% it is in position, no need for C-arm. Now I come back and see whether my infundibula, everything is safe, no bleeding. So I am injecting contrast with the nephrostomy tract and withdrawing slowly ampulla so that I can see if any colon or anything is injured. It will be diagnosed visually as well as the RGP wise. To conclude, I felt this stone might have been managed if it is stented, and if it is fan sheath but it will take an hour of time and not cost effective for a poor patient. But a PCNL combined with a short period of flexible scopy, again it is also costly, but if it is there in the system, it is not that costly, especially in a teamwork. So that's why I'm sharing this video. So ECIRS in this child has given the best result possible. Thank you.